There is fungus in viral land, Mucormycosis. There's been lots of panic in public and even in medical fraternity. To discuss all this, I have with me Professor Chand Wattal, Chairman of Clinical Microbiology and Immunology, Sir Gangaram Hospital, Delhi. Professor Wattal, welcome to podcast ISCCM.
Thank you for getting me here.
So my first question to you is, what exactly this mucormycosis is and where is the mucosine?
You see, mucormycosis unfortunately is being labeled as a black fungus, which is a misnomer. It is a group of fungi which we call as mucorales, and these are not black fungi. We have a group of black fungi separately, which we call as dimetaceous fungi. This is to put the record straight.
Okay.
Number two is it's a group of fungi in mucorales, where one of them is zygomycetes, which we are now calling as mucormycosis. So it is in the soil, in the air as the spores, and is an opportunistic pathogen in immunocompromised or high risk patients. So that is where it is in the nature. It is ubiquitous as all fungi are, and it's primarily in the air as spores or in the soil.
So since you said it's an opportunistic infection, it's already there, but why the incidence is going up in the COVID cases? Is there any reason for that?
Yeah, we did an audit ourselves, and we were not surprised actually, because those things are well known. There's a very deadly combination currently going on, that is the COVID infection and the pandemic that is galloping with its actually new mutant, which is highly infectious. It is in itself an immunocompromised scenario, number one. Number two, we are a diabetic capital of the world. Every another or every third or fourth person in India is a diabetic. And the worst part is that we have been seeing from the previous first wave of the last year that only two things have been helping the COVID patients. One is the oxygen and another is the steroids, use of steroids. And the use of steroids has been actually unabated from the last 1.5 years almost now. This is a deadly combination. When you have a significant risk factor and then at the same time you are giving steroids, which changes and pumps up the blood sugar levels. And blood sugar levels are a very good food for this cerebral-like fungus, which is a non-septate branching filamentous fungi that causes infection, and it primarily attacks the blood vessels and causes infarction of those. That is how the tissue gets dead and looks blackish, and people started calling it as a black fungus. So that is why in current pandemic we are seeing the rise of mucormycosis in a significant manner, but it is not even around 1 or 2% of in any COVID-19 cohort groups. So we need not actually panic, but be very vigilant and pick them up very quickly as if anybody complains of significant complaints pointing towards mucormycosis.
Here you came to my next question. As you said, okay, we need to be vigilant. So how do we have to be vigilant? How do we be looking for it, and and what are the diagnostic procedure to diagnose it?
You see, now you are trying to tell me as to how to suspect COVID-associated mucormycosis.
That's right, sir.
You see, patients with COVID-19 illness, active, recovering, or post-discharge, the common presentation is rhino-orbitocerebral mucormycosis. So it can be in the nose sinuses, it can be near the orbits as the eye swellings or loss of vision, or the cerebral abscesses. So initially, they may start with nasal blockage or congestion, nasal discharge, which may over a period of time become bloody or brown or blackish, and local pain on the sinuses. Then the facial pain or numbness or swelling may happen, headache, then orbital pain around the eyes, toothache, loosening of maxillary teeth, jaw involvement, blurring or double vision with pain, paresthesia, fever, skin lesions, thrombosis and necrosis, which we call as an HCAR, which is pathognomic of this disease.
Yes.
Such patients actually can also have pulmonary mucormycosis, which is well known. These are some of the primary symptoms and signs to suspect COVID-associated mucormycosis.
So, sir, these were the signs, and then how do we, as you said, we have to suspect, and how do we exactly diagnose this, and what are the treatment options available around?
You see, the diagnosis of mucormycosis is certainly that you have to do the appropriate radio imaging studies, primarily the MRI of paranasal sinuses with brain contrast study, and even plain CT thorax or pulmonary to get into pulmonary mucormycosis. So for rhinocerebral, rhinoorbital primarily, you have to consult an ENT surgeon or endoscopic collect and get the endoscopic collection of the debrided tissue or the biopsy. One portion of that should be put in saline for microscopy and culture, and the another portion in formal saline for histopathology and sent to the microbiology department. So that is basically the bane of its diagnosis. And it is, mind you, I deliberately said that it has to be primarily the tissue biopsy, which is the main sample and the appropriate sample to diagnose it. People have been sending the deeply taken swabs and all that, but the swabs have the disadvantage of not be able to tell you the invasiveness. As I told you, the fungus is ubiquitous and it could be as a commensal over there. It may not be causing disease, and it may show a mixed fungal infection, which again may be misleading. And when you do the biopsy, you get the true picture of invasion as well as the type of fungus which is causing the disease. So that is very important for us to understand for rhinocerebral or the mucormycosis.
Surgical guided biopsy is obviously the only option. Swabs are not.
Endoscopic biopsies are the best way to get the exact diagnosis, and it doesn't take very long. It's a very, by and large, a bedside procedure. The samples can be collected, and within maybe an hour or so, the smear examination can give away the diagnosis.
So, sir, what are the treatment options and how long to continue with the treatment?
You see, treatment, the treatment is actually, it varies. What you say is, you see, the primary thing is to control diabetes and ketoacidosis, because this fungus thrives on ketone bodies. Okay. So you have to reduce the steroids. As I said, that it pushes up the sugar levels. And obviously, that's the food for this fungus. And you have to discontinue if you are using the immunomodulating drugs. If patient is taking, like baricitinib or tofacitinib, these are some of the immunomodulators that are being tried on these patients of COVID.
Yes, sir.
And then surgical debridement, extensively remove the necrotic material. If the eye is involved, you may have to excentrate the eye. In pulmonary, if the lesion is there, localized, maybe even a small lobe that maybe have to be taken out. Oh. And then the medical treatment starts with putting in a central line to provide the access to the system of the patient to give the medicines meaningfully. So you have to maintain adequate hydration. So some of the normal saline infusions need to be given to the patient before, and then get on to the antifungal therapy. And the main therapy is liposomal amphotericin B. And it is preferred to be given by 5 milligram per kg per day. You can go up to 10 milligram per kg body weight in case the brain involvement is there. And it has not to be given in saline. It has to be given in 5% dextrose over 2 to 3 hours. And we have infusion pumps available this time. So you don't have to give a prolonged infusion at all. So you can give bolus therapies every 2 to 3 hours. And if there is a problem, you cannot give amphotericin B because of the cost considerations or non-availability, then you may have to be forced to use the native amphotericin B deoxycholate, where the dosage is different, say 1 milligram per kg per day in 5% dextrose in a slow infusion over 6 to 8 hours. and you may need to be very careful with this molecule. It can cause reactions. You will have to monitor the renal functions, the potassium levels while treating with amphotericin B. And patients who are intolerant to amphotericin B, alternative agents like posaconazole or isavuconazole, injections and tablets both are available. You may have to use those drugs. Posaconazole 300 milligram twice a day on first day, followed by 300 milligram once a day. And check posaconazole Prof levels. You may have to monitor the blood levels after 7 days of therapy and avoid interaction of the drugs. Similarly, isavuconazole around 200 milligrams 3 times a day for 2 days, followed by 200 milligrams once a day. And you will have to, as you said, how long you want to give this. What happens is that you have to monitor these patients clinically with radio imaging for response and the disease progression, and microbiologically also, maybe after 3 to 6 weeks of amphotericin B therapy. Consolidation therapy by step down to posaconazole, isavuconazole, or isavuconazole orally for 3 to 6 months will be required. Yeah, so that is how the usual progression of this is. And these are out of the guidelines that I am talking about, the COVID-associated mucormycosis guidelines published by the Fungal Infection Study Forum recommendations, and anybody can go onto the website of this. It's that is of Fungal Infection Study Forum, FISF. You can Google search and reach there.
Thanks for the information. So just my last question. Is there any role of dual antifungal therapy in these cases? Are there any cases which fits into any guidelines which suggest it, or is just not required?
There is not sufficient data as on today, but there have been some people where the aggressive therapy has been tried, where people are trying to give along with this some of the echinocandins as a combination, but the proven role of that kind of additive therapy is not really coming forth. So there have been people who advocate giving echinocandins along.
So obviously, as you very crisply explained, sir, there's lots of morbidity involved and mortality is also very high. And that is the reason why the hue and cry, and this is supposed to be very dangerous, right?
That's very true, and very mutilating surgery. You lose an eye or you lose part of the jaw and all that. So that is why it is very dreaded as on today.
Thank you, sir. Thanks for doing this for us. It was lovely talking to you.
Okay. Bye-bye. Thanks.
Bye, sir. That's all for today. ISCCM podcast is production of Indian Society of Critical Care Medicine. Thanks for listening. Stay safe. See you again.